One of the cornerstones of our rehabilitation approach is this, and those people who have worked at Headley Court will know that the exercise rehabilitation instructor is a linchpin of what we do. So the ERI, as we call them, is a physical training instructor, mainly military, some civilian, who then do an extra 6 months of training in delivering of exercise to the ill and the injured, and they're absolutely critical. Particularly, I might say, the military ones, because if you've got disheartened and disillusioned young men and women with multiple injuries, frankly, you need a bit of military ethos and, as we call it, grip to get the thing going. Otherwise, you can sit in the corner and not do what you're expected to do. And that's another thing. We expect them to get better. We expect them to attend rehabilitation. We expect them because they're on duty and they're being paid to get better. So group therapy involves using a large number, or a group of patients, of maybe a dozen, 15, and taking through this graded exercise program, hopefully through injury to health, in this sort of environment, but using a very broad and big multidisciplinary team to support that activity, from mental health to nursing in some of our cases, social work, occupational therapy, and psychology. I will say that in my view, formal psychological interventions, we don't use that a lot in our patients, except in brain injury, because there's too many. And actually, I think in most cases, this therapeutic milieu in which we work is the key to psychological health, and I'll show you some data on that in a minute. Using exercise therapy and all those modalities means you can deliver the most important thing in any treatment, and that's intensity. So we can deliver a full program of rehabilitation for pretty much as long as we need to. And that's a big difference between us and the NHS. Particularly even in specialist rehabilitation centres, you wouldn't be expecting to get 5 hours treatment a day, and we would. And that's allowing for time off to eat and rest. So I would expect our patients to be having 5 hours contact a day, be they a brain injury, multiple limb loss, or whatever. Now clearly some people can't tolerate that at the very beginning of their process, but we gradually increase that. So that intensity is critical to having an effect. I always say, what's the treatment of choice for a streptococcal pneumonia? Well, it's penicillin, but if you give 1 tablet a day for a week, the patient will die. Does that mean penicillin doesn't work? So the problem with a lot of studies and rehabilitation outcomes in the National Health Service is we give 1 tablet a day and say, well, it's not terribly effective, is it? So perhaps we should cut that resource and go into the surgery, hip replacement road. This thing about early intervention, clearly we have not just a complex trauma and neurological rehabilitation requirement. We need to be able to do, as you do, effectively be the medical team and the rehabilitation team for the team to get them back on the pitch. So we have what we called deployed or now force medical rehabilitation teams. So our physiotherapists are trained and our ERIs are trained to deploy with, in this case, a medical regiment which supports the primary care needs of battle groups and military units out on operations. So these teams are based with the troops and they will go to forward operational bases. We send consultants out there when we have the resources to do so, particularly at the start of what we call rouments, when big brigades are going out there, and we set up the systems. So a consultant will be part of that team, hence the photograph. But those teams will go as far forward as we legitimately can get our staff by helicopter or road move. They're fairly dangerous situations, so you don't want to be sending your physiotherapist into a situation where they're being mortared too frequently or shot at routinely, unless of course it's part of my disciplinary process. But they do, and so going far forward into company locations or even platoon locations to deliver the same thing that your sports teams get, because we want boots on the ground. It works, and this is data actually from Alistair Nicholl when he was out there, looking at over a period of 4 months, treated 211 personnel, and only 22% required aeromedical evacuation out of theatre. Now, these are musculoskeletal injuries, so we managed to keep 78% back in theatre. So that's over what we would call a company and a half strength of troops that didn't have to go back and went back to duty. Really valuable. That data is true in Afghanistan, in Iraq, in Bosnia, in Kosovo, wherever we've done it, they keep troops on the ground. They won't be treating these sort of patients because these people will stand on an IED, and in this case he gets his leg filleted. That's going to be coming back, and that's one of our complex trauma cases. Unless you've seen it, you will not comprehend the complexity of these injuries. They are being exposed to blast, burns, gunshot wounds, and all manner of complexities. So it's not just, oh, I've lost my leg. It's I've lost my leg, I may have lost my sight, I may have had a gunshot wound, in this case, through the femur, and also in that case, 70% burns. So managing that rehabilitation challenge is a challenge. We see a lot of talk about amputations as a result of Afghanistan and Iraq, and that's the nature of the patrolling system, what we're doing, foot patrolling. But as I say, there are other injuries as well, in this case facial injuries, visual loss, hearing loss, and the other issues around particularly bilateral amputations is if you've lost both legs above your knees, you may well have had significant or catastrophic genital injury as well. Developing systems to manage this has been a big challenge. And so this is a sort of a fairly standard case, not a particularly complicated case during the Afghanistan period. So bilateral limb loss, pelvic fracture, bowel damage, multiple finger and upper limb loss, and widespread muscle and tendon skin loss. Quite from a rehabilitation point of view, you know, if we want to get this person up and going early, then the simple issue of having a pelvic fixator on will limit them, unless we're liaising with the orthopaedic team about where that pelvic fixator should go and what angle it should be, for example. Now, this is a graph from our sort of acute colleagues, and it really illustrates the improvements that come with practice. We all know that. If you look at the 50% probability of survival rate, and you drop a line down, in 2003, the average score, in this case the new injury severity score, the NIS, which marks or measures the level of severity of the trauma, was around about 40. After a few years, in 2012, it's 60 plus. Now, put it in context, what does that mean? To get into a major trauma centre in the UK, you should have a score of 15 or over, okay? So a score of 45 is very, very seriously injured. In 5-6 years of training and treatment and practice, that score was up at 60. Now, you very rarely see anybody in the UK with that level of trauma score. 75 is considered to be incompatible with life. 75, we had about 100 patients who survived at a score of 75. So the skills of the acute services in terms of stopping catastrophic hemorrhage on the front line, using combat tourniquets and things like that, plus all the surgical interventions, has made a huge difference. It also made our job incredibly complicated. These people never ever survived in history. And those lessons, this is data from the NHS, this shows from the introduction of the major trauma networks, the survival rate, how it's improved. It depends what starting score you're at, that's the ISS score of 8. But depending how you look at it, there's probably at least a 40% improvement in survival rates in 5 years within NHS in England at least.